So it's the President Oration, and yesterday we have witnessed the historic moment, which was very much, I should say, a moment which everyone can relish, because it's always the first which matters a lot in your life, whether it is your, your first child, right? Or is it your first love, right? You do remember that. Okay. So with that, I should say one thing. I am his student. And not only me, I should say, many of you would have seen yesterday when we were talking about him, everybody, was saying something about him from the deep core of their heart. And they have lots of appreciation and respect, because that a teacher, you have to earn that respect. Not everyone can be teacher. That's what I believe in, because what we can say is a good education can bring the change in anyone, but a good teacher can change everything. And I think he is the one who is responsible for bringing out the change in many of us. And he is not only a good, mentor who has always supported, I think, many of us to achieve something in our life. And he is the force behind all of us. And that is the reason all of us, we are here today. So thank you so much, sir, for everything till date you have done for all of us. One thing which I would like to tell about him is not only, I was just telling that, not only he is a very good mentor, but he is a very, very humble person. So you do not learn just pain from him, but you learn how to not quit, in any of the situations which come across in your life. And he gives you that strength to, stand very strong in any of the situation and to just move ahead, right? So as personally, I have learned a lot from him, and how to respect everyone, whether they are juniors, your colleagues, or your seniors, because what I have personally learned from him is it is not only the seniors, it is not only your colleagues. Sometimes even people who are junior to you, they can be a very good teacher for you, because everybody is at different pace of their life when it comes to learning. You might be good in something, you might not be good in something, and the other person is, good at that thing. So you get that positive, vibes from the person who is very good in that subject. So it is like, you take everyone together, and then if you are going to walk, you will surely be reaching great heights in your life. This is what basically is something which we all have learned from him. And as you will see on Daradia's this thing, hospital, the logo is spread knowledge and happiness. So that itself, tells you how strong his message is for all of us, that it should be only the knowledge, it should only be the happiness which all of us, we should be talking about. We should be respecting each other. We should be involving in certain good activities to bring India, because he is our mentor. So I should say about my country that we should all work very hard to take India to newer heights and to make his dream, because he always says that it will be, I just want to see India somewhere on the top, equivalent to all the developed countries. So as a student of him, I feel that all of us should be working very hard, especially in the field of research, to make him proud. Because the moment you ask him, because sir, you have taught us so many things, then he says what exactly we can give him in return as a Guru Dakshina is the research articles. That's what I believe in. So we welcome you, sir. Please come on the stage. So big round of applause. And sir will be talking on lumbar spine sonoanatomy. So would you like to say something before you start your presentation?
So, thank you very much, Kanchan, for your nice words, encouraging words. As you told that, yes, it is true that you need not learn from the seniors only. we should be opening our mind to learn from the juniors as well. So your words also really encouraging words. And what we decided that the presidential oration should be something different this time. And it's not just like the other presidential oration. And here again, like yesterday, we'll be having the live demonstrations. So with the permission of the chairpersons, can I start my topic? Okay, thank you very much. So I'll be talking about the lumbar spine sonoanatomy and just short PPT. And after that, I'll start scanning. And in between, we'll be having some 3D anatomy as well to have a better understanding of the 3D anatomy. I can tell, yesterday also I was telling that I was a completely fluoro person. I started my career with in the pain medicines with the fluoro only. I'm talking about the late 90s, early 2000. That time, everything was blind or fluoro is also new, at least in my practice. I can remember I did my first lumbar sympathetic block with the blind with, if you can remember that day, earlier day. Nowadays, everywhere there is serum, fluoroscopy, live fluoroscopy. But that time, there was a, what is that called? In the OT, they're putting the plates and having the X-ray and then going to the, particularly in the orthopedic surgery, they are putting the nail, guide wire, and then having the X-ray, and then they are going to and bringing that X-ray to see whether the nail is right or not. Then again taking back, again putting another nail. So I started doing some of the procedures in that way only. Lumbar sympathetic block, I can remember, I was putting the needle first and then sending for X-ray. The plate was coming, checking whether it is there. Then I'm putting dye, again another X-ray, so another dye. In that way, I did the lumbar sympathetic block, I can remember. So those was the blind techniques, still image, and gradually we evolved into the CM, and ultrasound came much later. So earlier, many of in the audience visited our place clinic that time, and seen that time I was completely a fluoro person. And that time, we used to concentrate more on the spine. And even for the peripheral pain, we always have a thing that, okay, probably it is coming from the spine, because ultimately the nerves coming to the periphery are from the spine. So any hand pain, leg pain, we always used to blame it must be spine. And if there is any something bulging disc, something, we always, here is that problem. But gradually we understood that a lot of other things are there, particularly the musculoskeletal system and the nerves traversing between the muscle plane is a very important reason for the not only the peripheral pain, also for the spine pain and the truncal pain. So gradually the sciences has evolved like any other field of the medical science. It is regularly evolving. Every day it is evolving. What we learned yesterday is not holds true for today. So that is the reason this might be the only field in any of the other specialty. The medical field is such a field where you have to keep you updated each and every day. Sometimes when I tell at the age of my 60 years, I still read at least several hours per day to keep myself updated. Some of my students was used to surprise that, okay, still I read, but that is if we wish to be, still practice. If you're retiring from everything, it's fine. But if you still wish to be in the field, you have to keep updated. You have to read what is coming up. You have to think in your own way. So in that way, my knowledge about the spine has evolved a lot. So initially, when I used to do the spine procedures in blind technique, just now I told lumbar sympathetic block, I used to do the blind technique. Celiac plexus block, I used to do the blind technique. But gradually, we evolved into the CM. And then when we added the musculoskeletal ultrasound, the refinement was much better. Even, I used to do the endoscopic discectomy as well. And I was discussing yesterday with some of my colleagues who are also doing the endoscopic discectomy. I told, even in the endoscopic discectomy, when you are putting the guide wire into the disc, if you are using assisted by your ultrasound, there will be a lot of refinement. I'll be showing you that how you can put the needle inside the disc as well. And fortunately, our volunteer is very lean and thin. And I'll be able to show some of the disc structures also by the ultrasound. You can do something with the disc and the foramen under the ultrasound also. So that is how the things has evolved. And not only that, what I was telling, in the CM, you are seeing only bone. But when you are adding ultrasound, then what is happening that you are adding the precision. And spine is my, this is my most favorite area. So I have chosen this topic of lumbar spine. That is the reason in my presidential oration. So without wasting much time, let me go this. Again, yesterday I was telling, this presentation was also prepared by Dr. Kanchan. I just edited a few more slides. Okay, so parts of the lumbar spine. First, the bony part. So this is one of the vertebrae. You can see the different parts. This is your. Everybody is silent. I want to be interactive. What is this part? It is not, I'm moving it here, but it is not going there. I'm moving my cursor here. Okay, let me try the pointer. Can you see? Okay. So I was asking, what is this? Superiorticular process. And in the superiorticular process, there is a projection. This projected part of the superiorticular process. What is this? Mammillary process. Very good. What is this? Transverse process. What is this projection in the transverse process? Accessory process. I'll be showing you another, that there is a ligament called the mammulo-accessory ligament in between these two. And through this groove, something passes. Median nerve accompanied by some artery. Okay. What is this? Lamina. What is this? Spinous process. What is this? Inferior articular process. Very good. So this is from the, when we are seeing it from lateral view. So vertebral body. Now transverse process has become thinner because we are looking from laterally. Now the spinous process is bigger. This is your superior articular process. So these are the, ultrasound and bone, whether they are friend or enemy. Sometimes friend, sometimes enemy. Ultrasound, bone do not allow the ultrasound to pass. So you cannot see anything beyond bone. But again, bone is a friend as well. Why? Because looking at that point, you can relate the other structures, that is my point, and from where you can relate the other structures. So it is both friend as well as enemy. So if you wish to look the inside spine, so spine is all around bones. So you need to have some windows through which you can peep and see what is there inside. So what are those windows? One of the window is between the two spinous process. What is another window? Between the two lamina. What is another window? Because this is a bone, but disc is not a bone. So through the disc, either laterally or anteriorly. Today, volunteer is good. I'll be showing you disc and spinal canal from anteriorly as well. You can see the disc architecture through anteriorly, because the disc itself do not obstruct the ultrasound beam. So these are the different windows through which we can peep and look at the structures, what is there in the spinal canal. Sorry. So these are the ligaments, interspinous, supraspinous ligament, and ligamentum flavum, through which also ultrasound beam goes. And this might be the pain generator subtypes, particularly supraspinous and interspinous ligament. So now coming here, I was talking about this. So this was the accessory process. This was the mammillary process. This is the mammulo-accessory ligaments and a blood vessels and the nerves. Nerve may not be seen nicely majority of the times, but you can see the blood vessels nicely, and you can understand that this vessel must be accompanying the nerve. So this is your cadaveric dissection. So this is your mammulo-accessory ligament, and nerve is coming below it. This is another area, intertransverse tissue complex, ITC. So what is that? Between the two transverse processes, there is some tissues are there. So if you are going from posteriorly, the superficial one is this gray structure is your intertransverse ligament. Then this is the muscle which is called intertransverse lateralis muscle. There is another muscle which is between these two that is called intertransverse medialis muscle. This is intertransverse lateralis muscles. And some soft tissues are there. Together, it is called intertransverse tissue complex or ITC in front. So when you are doing endoscopic discectomy, when you are putting the needle, normally you'll be getting the resistance here. So when you're putting the guide wire, the first resistance what you'll be feeling in these areas, intertransverse tissue complex. And after that, you'll be going there. And when you are putting it, particularly the extraforaminal approach, you are not inside the disc, your scope will be still fixed. How? Because these tissues will be holding your probe. If suppose this is the disc, if your disc is here, even outside the disc, your scope will not be moving much. Why? Because these structures will be gripping your scope here. So when you will be going here, this is very important structures when you're doing the endoscopic discectomy. And just anterior to that is your neurovascular bundle plane. And after that, the psoas muscle and the ventral rami of the nerve roots then goes anteriorly within the psoas muscle. So this is an MRI. So these are the erector spinae group of muscles. And we know that there are three muscles. What are those three muscles? From medially, it is multifidus, then iliocostalis and longissimus. So there are three erector spinae group of muscles. And this red is your quadriceps. And this is your psoas. And this is the spinal canal. As I was telling, today I'll be showing you because I am very happy to see this volunteer that, and he is empty stomach. He has not taken any food in the morning. I told, don't take any food right now. He'll take food after my scanning is complete. Okay, so what are the probes we are using? So because we are working in a deeper, normal build. In this patient is lean and thin. Here, I was just scanning. I saw that within 8 centimeters, I can see everything. Anteriorly, little deeper. But normally, we need a depth of approximately 10 centimeters, 8 to 12 centimeters in a normal. If the patient is obese, it might be up to 15 centimeters. So what probe we need? Curvilinear. But when you are looking about the superficial structure, you need a depth of approximately 5 centimeters. So you can use again curvilinear, but you can today I'll be using one, the linear probe with better little lesser frequency around 12 megahertz. I'll be using that because patient is lean thin. Because most of these structures is within 5-6 centimeters I have scanned today. So, but most of the times we are using the curvilinear probe. And if you wish to see the very superficial structures, like the interspinous, supraspinous ligaments, then you can use this linear probe. Then the position. And, most important is prone position. So most of the time, pain physicians' position is your prone position. So particularly the facet joints, medial branch, you must be using the prone position. Sitting position is a preferable position for the anesthesiologist, but for the pain physicians, we don't use it. But sometimes some structures are better seen when you are flexing and the gap between the two spinous processes increases, you might be seeing the structures better. And otherwise, what you can do, you can put a pillow and we can decrease the lumbar lordosis for the better visualization. I'll be doing that only. Prone with a pillow under the abdomen. Lateral decubitus also, particularly if we are doing the, the quadratus block and some other lumbar sympathetic, you can use it. That. And another position is not shown because we normally don't use it. That if you wish to see the disc and spinal canal from anteriorly, then you need to have the supine position as well. Now the position of the probe. So this is your medial sagittal view. So this is the midline. You are putting it there on the midline. Then your paramedian sagittal. You are coming little bit away from the midline. So normally we start with this only, paramedian sagittal, and then gradually we go towards the midline. And paramedian sagittal oblique, you can tilt it. But there are certain other probe positions, and I'll be telling you one of our own technique of visualizing the foramen, and that is some more tilting and some more manipulation, which I'll be showing you when I'll be doing the scanning. Now, other is here, the transverse or short axis view. It can be over the spinous process, or it can be in between the two spinous process. When it will be over the spinous process, the picture will be all like a temple, and then we can. So these are the different positions. First, normally we scan it like this, and if we are putting the probe over the, normally we do it start from the paramedian positions at this, and what we'll be able to see, this will be able to see the transverse processes. It looks like a trident or finger like projections. This will be the acoustic shadow by the transverse process. This is the erector spinae group of muscles, and in between the two transverse processes, we'll be having the intertransverse tissue complex. And after that, so neurovascular bundle will be here only. After that, the psoas, and after that, the peritoneum and the intra-abdominal structures. So now, if we are moving the probe towards the midline, and if we are over the articular process, so this is called articular process view. We have MCQs, all these, remember it, if you wish to get a trophy. So that is facet joint view, articular, the process view, and there it is called also, looks like a camel hump. So it is called the camel hump view. And these are your articular process, superior inferior articular process. And if you are moving more towards the midline, and then what we are going to see, look at the picture. So this is called horse head view. So what we are doing here, we are putting the probe on the paramedian area, and then we are tilting the probe to see through the two lamina. So interlaminar view. So this is lamina, this is lamina, and through this you can see ultrasound beam can go, and you can see the anterior complex. Anterior complex means it will be having the anterior dura and posterior longitudinal ligament and vertebral body cortex. Altogether is your anterior complex. It may not be, we may not be used to separate each structures nicely, and that is the reason why we take it together, anterior complex. And then there will be the black area to which the CM beam will be passing without having any shadow coming back. Then we will be having the posterior complex. So in the posterior complex, what are they there? We can, here we can identify. Normally these structures are better seen because it is more superficial. So first layer will be your ligamentum flavum, and then there will be some space, black line, and then there will be your posterior dura. And this together is called the posterior complex. And if those who are anesthesiologists, if they wish to do the ultrasound assisted your spinal or epidural, particularly some difficult cases, like say, for example, somebody is having the ankylosing spondylitis, spine is fused, and you are not able to go inside, then you can scan it and you can find it out. Some normally not completely fused everywhere. So you might be able to find out some gap. If you see that the ultrasound beam is going nicely here and you can see this anterior complex, that means you are able, will be able to go there inside. So this ultrasound assisted spinal or epidural, this view is important. Then counting the vertebral level. So as you all know, that the sacral vertebrals are all fused. So when you are probing over the sacrum, it will be a continuous. Beyond that, you can't see anything. So continuous bony outline. After that, when you are moving above, you will be first space where the ultrasound beam will be passing. That will be your L5S1. But again, in our center, we always count with the CM. Because fallacy here is, if there is a lumbarization, if there is sacralization, this might be giving a false impression. And that is the reason always counting is better done by your X-ray or CM. As I told, in our center, all the spine cases we do in a hybrid technique. Wherever you are pressing the needle, we are always checking whether we are at the right level or not. Then spinous process view. So in between the two spinous process, through spinous process, we'll be able to see the structures there. Counting the level again on the midline also we can do the counting. But as I told you, counting I don't like this way. Now the spinous process view, it can be over the spinous process and they will be able to see 3 steps. First step is spinous process. It's like a temple. And first process is your the spinous process. Next step is your lamina. And then next step is your transverse process. And this is the area where we'll be able to see the medial nerve, vessels accompanying the medial nerve. And this is the area where we can go for the intra-articular facet joint injection. So this gap can be seen. So basically we need to tilt it little above and below to find out this joint. And this is the erector spinae group of muscles. Now this is foraminal view. This is our own technique. What I'll be doing, I'll be just telling you that time that first we'll be putting our probe here over the spinous, over the transverse process, and gradually when we'll be moving towards the articular process view, camel ham view, we'll be able to see this projection, mammillary process, also called the mammillary process view. After that, the cranial end will be coming back here over the transverse process, and then we'll be able to visualize the foramen very nicely. And you can see the nerve root, you can see the blood vessels accompanying the nerve root. That also we are going to demonstrate. So now let us go for the demonstration. And if you have any quick questions regarding this, the slides what I have demonstrated, you can tell me, ask me.
Thank you very much, Dr.
Volunteer.
Gautam Das. As said, Dr. Kanchan is our teacher.
Some of you come
Not
here.
all of us,
And volunteers.
at least big part of us. So we are proud to be chairperson for Dr. Gautam Das. And I will just need to say some words about this nice teacher. Just that in Sudan, we said the happiness does not depend on how happy you are, but how others can be happy because of you. So we are just happy because we are learning from this gentle doctor, nice science, nice procedures, nice and very valuable techniques in pain management. Thank you very much for this nice lecture, and I hope to continue our words. Thanks.
Okay, just give me 1-2 minutes time to prepare the volunteer. Okay, I hope you can see the volunteer position as well. Yes? Okay. So just quickly about the 3D anatomy. What is this muscle? Latissimus dorsi. So I'm hiding this muscle. Then let me bring this little above. This is your longissimus. And below that, medially, is your multifidus. This is your iliocostalis. And these three together is your erector spinae group of muscles. And if you wish to do the erector spinae block, many of you are doing it. What you are doing it? You are putting it here over the transverse process. And posterior to that is your erector spinae group of muscles. And similar kind of thing is your the dorsal ramus block. It's almost similar. Somebody I can remember in one of the classes telling that, sir, tell me about the dorsal ramus block. So I was not doing dorsal ramus block, but later on I read it. So dorsal ramus block and erectospiny block is almost similar. So your needle should be there on the transverse process, and you have to give that depending on the volume, how much volume you are giving it. And that is what is dorsal ramus block, or even the medial branch block also is similar. The needle placement in all these three should be same. You should be putting your needle on the transverse process. For the medial branch, you should be going to the medial most corner part of the transverse process. For the erectospiny or this, you need not be so medial. You can be anywhere in the transverse process. So let me remove these muscles also. Abdominal muscles. And then what is this? Quadratus. Remember, quadratus is starting from the lateral most part of the transverse process. So when you are over the transverse process, you can see which muscles. Most superficial will be your erectospiny, then your transverse process. In between the transverse process, which muscle? Intertransverse lateralis muscle. And beyond the transverse process, psoas muscles. That is when you are over the transverse process. But when you'll be moving laterally beyond transverse process at this place, then only you'll be able to, again, erectospiny, then quadratus, then your psoas. Then these three layers of the muscles. Okay. So this anatomy will be there. I'm putting here. It is in the third camera. And let me start scanning. Please come. First, give me the 12 megahertz bulb. You just stand here. Stand here. And you'll be making it freezing when it's needed. And make the annotation features when I'll be telling you. Not now. How long can I demonstrate? How much is my time? 9:20, only 20 minutes. Okay. Okay, what is this view? Transverse process view. So transverse process view, what are the structures there? Please, karo. Please come here and annotation. Pen. Okay, this is transverse process. This is transverse process. This is your intertransverse tissue complex. This is your erectospinal group of muscles. This is your psoas muscles. But I'm not happy with the picture quality. Yeah, unfreeze karo. Okay, so now this was the transverse process. So I'm going laterally. I'm moving it. So this was your better view of the transverse process. Now I'm going laterally. See what is happening? What is happening? See, another muscle starts in between. Can you appreciate that? So I was here, transverse process, and then I'm just going beyond. So, please. So transverse process has now vanished, and two hyperechoic line, you can see, here it is very close. So what are these two lines, hyperechoic lines? Hyperechoic lines, thoracolumbar fossa, very good. So this is your anterior layer of the thoracolumbar fossa. This is your middle layer of the thoracolumbar fossa. And thoracolumbar fossa, basically anterior and the middle layer enclose the quadratus lumborum muscle. Okay. So I'm going more medially. You see that what will happen? More laterally, sorry. So now the quadratus muscles, you see, gradually its girth is increasing. And you see psoas muscles, what is happening? Psoas muscles width is gradually decreasing. You see the peritoneum is moving. I'm increasing the depth little more. Sorry. Increase the depth. Okay. So you can see the peritoneum moving. Above that is your psoas muscle. So if you're moving it laterally, what is happening? The psoas depth is decreasing and quadratus depth is quadratus. You see here here the quadratus is starting, the middle one. Quadratus is starting. I'm going laterally, that in between the two thoracolumbar fascia, the quadratus is increasing. Here you can see, please karo. So what you can see here, we came little laterally. You stand here, no? So what is this? What is this line? Middle layer of thoracolumbar fascia. What is this? Anterior layer of thoracolumbar fascia. What is this? Quadratus. What is this? So now psoas has thinned out. Quadratus width has increased. Okay, now clear karo. Please unfreeze karo. Now I am going from this level. I was here to transverse process view. So at this transverse process view, let us see the structures. What you can see here. Please karo. So this is transverse process view. So what you can see here. So intertransverse tissue complex. And what are the components there? It normally starts with the hyperechoic line there, most above one. That is your intertransverse ligament. And from here, this is this muscle in between the black area. I'm just removing it. You see, can you see the two hyperechoic line? And in between there is a black, you see a muscle. That is your intertransverse lateralis muscle. Intertransverse lateral. Here it is very seen very nicely. Many of the times this is not seen very nicely. Intertransverse lateralis muscle. After that, immediately, this is your neurovascular area. And ventral rami branches will go inside into within the substance of the psoas. Okay. So I was here, transverse process view. So now I am going gradually inside, medially. So now what is happening, you see? Suddenly, this area was your transverse process area. This area was transverse process area. And if I am going here, you see, suddenly the bony projections are changing. Can you appreciate? So here the bone was deeper, transverse process. Here the bone is superficial. What is this? Please karo. What is this bony processes? Mammillary process. The first most prominent bony projection what will be coming when it will be coming from lateral to medial will be your mammillary process. This is also called mammillary process view. So this is your mammillary process view. Everybody can appreciate? So this is not the typically camel hump view. Typical, if you are going little more, then the camel hump view will be coming. Okay? So this was your just tip of the mammillary process. As I told you, mammillary process is most projected and little bit of laterally projected. So when you will be coming to the here, it is not the typical camel hump view. This is your camel hump view. And if you are going till more medially, then you are having the, what is this? Horse head view. And now if we are tilting the probe, what you can see here, now the anterior complex, posterior complex, interthecal space is very nicely seen. So this view is called this. What is this view called? Horse head view. Okay. So this is looking like a horse head. Horse head. So this is the area through which the ultrasound beam can penetrate. So what you can see, this is your anterior complex, and what is there is your posterior complex. So in the posterior complex, the most superficial was your posterior dura, ligamentum flavum, and this is your posterior dura. This is there in the posterior complex. Clear karo. I'm showing you it again. So I was there in the transverse process. Then I am getting the mammillary process view. Then we are getting the horse head, camel thumb view. This was camel thumb view. And then your horse head view. And then you can see the anterior complex, posterior complex. So if somebody is interested, somebody is anesthesiologist. So here you can see the two layers very distinctly. Freeze karo. Both anterior complex, posterior complex layers are very nicely seen. And you can see some of the pulsations there in the anterior complex. Can you appreciate that? So you should remember that the dura is very rich vascular structures. So you was able to see the pulsations there. So here in this area, in the posterior complex, can you see the two lines and in between that a black area? So that is what? Epidural space. Very good. So you can see that very distinctly. So the anterior horizontal line, that means this one is your what? Posterior dura. And this is what? This was your ligamentum flavum. In between these two, black area is your epidural space. To be more precise, posterior epidural space, because there are other epidural spaces as well. Anterior epidural space, lateral epidural space. Epidural space is encircling everything. So here you can see, because as I told you, patient is lean and thin. Here you can see anterior epidural space also. Not always in anterior complex, as I was telling. Most of the times anterior complex is a little bit of hazy. But here you can see distinctly the two structures. The most hyperechoic structures below is this one. This one is the vertebral body and the posterior longitudinal ligament together. They are adherent. And then there is a distinct line that is your anterior dura. And the space in between these two is your anterior epidural space. Clear it? Okay. So now let me do the transverse scan. So transverse scan, what I was telling, sometimes we will be on the spinous process. Please. So we are on the spinous process. Why? Because we can't see anything. It's a temple. We can see the 3 steps. 1 step, spinous process. We can't see anything. The spinous process. This is what? This is your lamina. And then this is your very nice facet joint. Facet joint is not always seen very nicely. I'm just showing you with the pointer. So this is your facet joint. Okay? Can everybody appreciate? So in some book it is written, a facet joint is better seen when you are in between the two transverse processes. But that is not true. That is not true. You have to scan. You have to scan and you find it where it is better seen. Because as I'm telling you, that anatomical variation is always there. So sometimes, what the textbook is saying with the pictures, it may not be holds true for your patient. So that's why you must be having a very sound anatomical knowledge and you have to correlate with the scanning. So what I was going to tell you here in this patient, you can see when I'm putting my probe over the spinous process, I can see the facet joint very nicely. You cannot see better than this facet joint, but it is not over the in between the two spinous process. So it is not a fixed rule that your probe should be over the spinous process, in between the two spinous process to see the facet joint. You just tilt your probe and you see. So what we are seeing here is your 3 steps. One is your, sorry. So one is your spinous process, then is your lamina, and then is your transverse process, right? Clear. So again, you see, so nice facet joint. I'm tilting the probe above and below. Just concentrate on here. Here. See the facet joint. Okay? So this is not a fixed rule. This is if you wish to do the intraarticular facet joint injection, you have to come like this. Like this. And now I'm coming laterally. I'm keeping my, the spinous process on the right hand side. And you can see the aspect marker on the lateral side. And my probe is over the spinous process. Why over the spinous process? Because I can't see anything. When I'm tilting the probe, you see, now I can see the structures going. So this is in between the two spinous processes. You can see the anterior complex. So this was your anterior complex. This was your anterior complex. So it is moving. That means it is in between the two spinous process. Now when I'm here, this is not over the this is over the spinous process. We can see the structures there. And this was your facet joint, what I told you. And now I am concentrating, I am tilting, taking the probe more laterally. And now I am moving above and below. You see here, you can see the CM ultrasound beam is going down. That means, and which place we are? In between the two spinous process. If I am going here, tilting the probe above, you see, now what is happening? Now you can't see anything. That means I am over the transverse process. So here, if I am focusing, if I am coming here, so what is depth? So you see here, this is your transverse process. Why? Because I can't see anything beyond it. So now focus on there. So this was your the lamina. This was your transverse process, and you try to focus, and you'll be able to see some pulsations there. Okay, you focus in this area, and you will be able to see pulsations there. Okay, now it is seen. Here you see. Here. So that is the area for the medial branch. That is the area for the medial branch. See this area? If you used to do the medial branch block, your needle should be coming from here. And what I was telling here in this area, CM beam is going down. So this muscle is your psoas muscle. This muscle here is your, what is this muscle? Quadratus. And this was your, so this was your middle layer of thoracolumbar fossa. Be more precise. This was your anterior layer. This was your psoas muscle. This was your QL muscles. Most medially was your multifidus, then your longissimus, and then is your iliocostalis. Very good. Okay. So now let me see in between the two transverse processes what we can see. In between the two transverse processes, this is also called the bat's view. It looks like a bat. Sorry, depth come. Little more. Okay, yes. So you see here that now I am in between the two transverse process. So if I am in between the two transverse process, what we can see? We can see this pointed. So this was your anterior complex. And again, if you are looking very precisely, can you appreciate two lines? So the deepermost line is what? Posterior longitudinal ligament with the posterior cortex. And above that, there is a black line. What is that? Anterior epidural space. And just above that is your anterior dura. And together is your anterior complex. Okay? So this is your bat's view. Fine. So now I'll be using the curvilinear probe because I wish to. Normally these are also done by the curvilinear probe. But okay, I forgot to show the foraminal view, our own technique of doing transforaminal in long axis. After that, I'll be going laterally. So here, what I was telling, when I was starting, as I was scanning from here, so I starting from here. So here there is no transverse process. We can see the QL muscle. We can see the two layers of the thoracolumbar fossa. We can see the erector spinae muscles, psoas muscle. Now I am going medially. So now the transverse process is coming. So transverse process view. And if I am going more medially, so what is this view? Mammillary process view. So now what I am doing here, at this point, I am keeping, at this point, I am keeping the distal end on the mammillary process. I am tilting back. So this was your transverse process. This is your mammillary process. This is more superficial. This is deeper. And this is your foramen. And look at here, what you can see here. So here you can see the nerve root accompanying blood vessels. I'm not freezing it. I'm just doing the light scan. You can just see the pulsating vessels there. Dip thoda aur So this is your foraminal view. And here, so this is your foraminal view. And here, this is the nerve root. This is the pulsating blood vessels, nerve root, pulsating blood vessels, and the USG. Hey, and we can see the USG beam is going deeper into the, this is the disc. The USG beam is going into the disc. So if you are putting the needle into the foramen, normally what happens? When you are doing the discography, what do you do? You go through the foramen and go inside the disc. So this is the view with which you can do the same thing. So again, see what I am doing. So I am over the transverse process. This is the transverse process view. I am moving more medially. Now what is coming? Mammillary process view. At this position, I am taking the cranial end back, tilting it back, and hey, don't move, huh? So at this position, please karo. What we can see here, that this was your what? Very good. What is this? Transverse process. And this is the foramen. And the USG beam is going down into the disc. And here you can see the blood vessels also pulsating. Time over. But I need another 5-10 minutes. Is it allowed? So this is, if you are putting the needle like this, you can come in plain view, you can go. And we have correlated with the CM, giving the dye, nerve root can be very nicely visualized. And if you're putting the needle further, you can go even into the disc. Okay, so curvilinear probe.
Okay, thank you very much.
No, I need 3 more times. I have not yet completed this. Okay. Depth increase around 9 centimeter, 8-9 centimeter. Okay. So now patient is prone and I'll be holding the probe from laterally. And my aspect marker is anteriorly. That means the structure, what you will see this left-hand side is your anterior structures, and the structures what you will be see on the right-hand side will be your posterior structures. And I am holding the probe like this. Hip, hip, hip. So you see, I am pushing it like this. Or we can do in the lateral decubitus to show the structures better. तुम्हें काम करोगे बेटा मेरा ऐसे करके बैठो
ये उठाना है बेटा सब छतरी
मेरा तरफ आ जाओ थोड़ा
ये उठाना है और ये उठाना है इसका ख्याल रखना
patient positioning is very important for
Dr. Arshi, please mute.
proper मेरा तरफ आ जाओ
यही रखना है।
It can be done also in the prone position.
Arshi's phone, please mute.
But this will be helping me to show you better. So what I'm doing here, you can see I'm putting the probe here. Patient is in the lateral decubitus. And as I told you, my aspect marker is anteriorly. That means what you can see is your left-hand side is your anterior structures. And what you can see here, the posterior structures. Okay. So, pointer. Pointer. So, now tell me, what is this? Huh? Transverse process, very good. What is this? Vertebral body. What is this? Pulsating? Aorta, very good. So now, see, I'm tilting the probe above and below. So now at this position, transverse process has gone. So what is this? Foramen. What is there in between the two transverse process? Foramen. So this is your foramen. And this is, look at here very nicely. Can you see any pulsation there? Can you see pulsation? So this is your blood vessels accompanying the nerve root. What is this muscle? Very good. What is this muscle? QL. What is this muscle? Very good. So suppose if you wish to do a transforaminal injection. So what you should do? You tilt the probe between the two transverse process. Now transverse process is vanished. So take your needle from here. Okay? So you can do the foramen transforaminal like that also. But this approach is better for the lumbar sympathetic. Suppose if you wish to do the lumbar sympathetic is situated is what level? At this level. This is the anterolateral border of the vertebral body. So your needle will be coming like that. And you can do a lumbar sympathetic block. So there is another block called Ramai communicants block. I don't know how many of you have heard it. It is basically written more in the history book nowadays. In our times, it was, the very popular block. We used to do the block. Nowadays, it is very obsolete. This is how it should be coming. It should be coming in the middle of the vertebral body. If you are coming here, it is a lumbar sympathetic. Here is your foramen. Here is your foramen. And these are the different blocks. Okay, in this position, you can do another block. That is your QL, that is your psoas block. Psoas block should be coming here. Within the substance, you can see some cleft is there. So this plane is there through which your ventral rami of the nerve root passes. So if you wish to do a psoas block, exactly where my needle is, where the cursor is, that should be your area for your psoas block. Okay? Okay, let me tell you other things. What is this? Lamina and spinous process. Okay? Now I'll be showing you normally I'll be using the same probe. Wipe out. Tissue kahan pe hai? Okay, in this view, when the transverse process was going away, you have seen probably that the ultrasound beam is going through and through. That means you are in between the disc. But I got a good volunteer, or I can show you it as well. सीधा लेटो, सीधा। ठीक है, सीधा। Okay, so many of you are accustomed with the superior hypogastric plexus block. So here where the aorta is bifurcating, that is the area. So now, if I'm holding the probe here, what is this? Vertebral body. Here it is aorta. So what is that level? It is bifurcating, means L5. Very good. So now if I'm tilting if I'm going above, what is this area? L4-5 disc. And what you can see here is your spinal canal. And this is your foramen. Okay. Can you appreciate? So this is your L4-5 disc. And so this is your spinal canal. This is your foramen. I'll be showing you again, and you'll be able to see something pulsating here is the nerve root accompanying the blood vessel. Clear it. You see? And if you wish to see the suppose prolapse disc is there, and if the patient is lean and thin, you can see the prolapse disc also. If you are, in this area, whether you can appreciate whether your disc is prolapsed and obstructing and compressing the nerve root also. So this is another way, to see if your patient is lean and thin. You can see the the disc and the foramen. So thank you very much.